I'll make fun of his car again if you'd like. We did find his aux port the other day, just so you know. I hope he shared that with you.
I haven't had a chance.
All right, let's talk about internal bleeding. What's the difference between internal and external bleeding?
One's on the inside, one's on the outside.
Ding, 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 we have another winner.
He's known for direct answers.
That's right, one's on the inside, one's on the outside. What does that mean for you as an EMT?
Harder to see.
When you
It's
can
harder to see.
see, and when you can't.
One you can see, one you can't. That's right. So internal bleeding is harder to see. Does that change how you're going to treat your patient?
Yes.
Yes.
It is going to change how you're going to treat your patient. Why?
Because you're not going to apply a tourniquet to them.
Because you can't apply a tourniquet. In my high school class, I have my students write questions up on the board before we discuss the lecture for that chapter so that I can make sure that they've already read the chapter. Because it's really boring to do a lecture when nobody's already read it. Hint, hint, hint. But one of them asked me, it's actually up there on my quote board somewhere, why can't you use a tourniquet on internal bleeds?
Cassie.
Why can't you use a tourniquet on internal bleeds?
You have to open them up.
Because you have to identify where the supply is coming from, and if it's inside the body, you can't get a grip on it.
You can't get a grip on it, yeah. Can't use a tourniquet on an internal bleed. Okay? How can we stop the bleeding internally?
Take them to a hospital.
Take them to a hospital, because we can't stop it. Right? How are we going to recognize if they have internal bleeding?
There could be large bruising.
Signs of shock.
Yeah, we're going to see signs of shock. We're going to see bruising or ecchymosis.
Also deformity.
We could see a deformity. We're going to see or could see rigidness, tenderness, swelling. Now, does any of this automatically mean that they have internal bleeding? No, you got to look at the other things that are going along with it, right? So, what are some of the things that can cause internal bleeding?
Trauma.
Blood trauma.
Okay, so we have trauma or trauma.
Okay.
What else?
Broken bone.
Broken bones could cause internal bleeding. That's a type of trauma, but yes.
Oh, cool.
If they don't start bleeding, because of the trauma itself, let's take a look at a femur, right? If the femur is broken due to trauma, the femur could potentially slice through the femoral artery, right? So the broken bone itself could cause bleeding into that cavity, okay? What else could cause internal bleeding? And let's think about our thoracic cavity, our abdominal cavity, our pelvic cavity. What else can cause internal bleeding?
Ulcers.
Pardon?
Ulcers.
Ulcers, yeah, ulcers can cause internal bleeding. Where are ulcers going to cause bleeding at?
Stomach.
In our stomach or in our gastrointestinal system. Okay, so what are we going to see? What is a sign that our patient is dealing with ulcers?
Stomach pains. And
They're going to have, okay, they're going to complain of stomach pain. Is that a sign or a symptom?
That's a symptom.
That's a symptom. So what is one of the things that we're going to see?
Blood in their
Or,
vomit/stool.
yeah, they could have blood in their vomit/stool. What is that called?
Melena,
Okay,
melena,
melena.
or
Hematemesis.
yeah, that one.
So melena means black, right? So you have black, tarry stools, and you have coffee ground vomit. Okay? What else could cause internal bleeding?
Disease process.
We
Such
can have
as-
disease
such
processes.
as cancer.
Okay, we have disease processes that can cause it. We can have a lacerated liver. We're going back to trauma here. Or we could have a ruptured spleen. Okay, any of those things can cause internal bleeding significant enough that it could be a problem for your patient. Are there other things besides this? Oh yeah. Oh yeah.
Aortic aneurysm.
Yeah. Anywhere a person could get injured, almost anywhere a person could get injured, it can cause significant enough bleeding that they could go into shock and potentially die. Okay? Did we discuss DCAP BTLS? We did, because you brought up the paper that you gave me the other day. Okay. We have ectopic pregnancies that could cause that. Okay. Or aneurysm. What's an aneurysm?
Like a weak spot in the blood, in the artery or
In the vessel.
vein,
Yeah, in an artery. Why does it exist in an artery and not in a vein?
because you don't have
Because of
pressure. in
pressure.
it.
Because you don't have pressure in the veins, right?
you
So an
don't-
aneurysm is a weak spot in an artery. Aneurysms are one of the causes of strokes. There are two types of strokes, which you don't care about right now, really. But there's hemorrhagic and ischemic. And hemorrhagic is the result of an aneurysm. Okay? Excuse me. Okay, so we have bruising, deformity, rigidness, tenderness, swelling. What else might we see in internal bleeding?
If there's blood coming out of like their body openings, like anything like that, out of their ears or out of their mouth, or
Okay, so we may see blood exiting other openings. Not what I was going for, but very definitely an answer, right? And it's an answer that's a legitimate one, so I'll include it up here. Okay. We may see guarding. What is guarding?
You're holding that area, trying to keep it from anybody from hurting it.
Right, trying to protect whatever the area is that's injured so that if somebody touches it, it doesn't get hurt. Okay? How about distension? What's distension?
Swelling.
It is swelling, but it's a little bit more than swelling.
Would that also fall into deformity?
It would fall into a combination between swelling and deformity, because distension is kind of excessive swelling and more typically confined to a description of the abdominal cavity.
or your jugular veins,
Pardon?
or your jugular veins.
Yeah, yeah. Okay, so we talked about signs and symptoms. So some of the things we might have forgotten I don't even know what I'm talking about, pain. Depending on where your internal bleeding is at, you might also experience some difficulty breathing. Why might that happen?
If there's blood filling the thoracic cavity, then it'll have like the lungs will have a hard time expanding.
Okay, so the lungs might have a hard time expanding because we've got blood in the thoracic cavity. What if we have blood in the abdominal cavity that's not allowing our diaphragm to go down?
That too.
That too. What if we have blood that's gotten into our bronchioles or our alveoli?
Spitting up blood.
You
Spitting
could
out
be
blood.
spitting up blood, you could be coughing up blood, right? But all of those are reasons that we might have difficulty breathing when we're dealing with internal bleeding.
You'll have your heart, the same thing. I mean, it'll be like the obstructive shock. Like you
Yeah.
said, there could be.
So we could see changes to our heart rate or to our blood pressure, right? Okay, let's see. We also might see our typical symptoms of hypoperfusion. What are our typical symptoms of hypoperfusion?
The change in blood pressure.
Yep, we're gonna have a change in blood pressure. We're gonna have a change in heart rate. We're gonna have a change in respirations. We're gonna have a change in mental status. What are some of the later signs of hypoperfusion that we need to worry about?
Cyanosis.
Cyanosis. What else?
A drop in your blood pressure, heart rate, or respiratory rate.
Okay. What else?
Loss of body temperature.
For a pediatric patient who has a capillary refill time of greater than 2 seconds, that could be a sign that they're suffering from internal bleeding. We're going to have nausea and vomiting. And guess what? Nausea and vomiting, they don't go really well with thirst. Right? You're thirsty, oh, you want some water? No, it doesn't work well. It doesn't go well together. We're going to see dull eyes. What does dull eyes mean?
Not getting moisture to your eyes.
It's not about moisture.
More yellow.
You get a look to them. Dull.
Have you ever kind of seen someone, have you ever seen someone who isn't exactly paying attention to what's going on, but they're kind of looking off with, you know, they're not paying attention. They're obviously not interested. They're just kind of looking off over whatever, and you can tell that their eyes are kind of glazed over. Okay? That's not exactly dull eyes, but that's probably the closest way that I can describe it to you. You can tell when a person isn't interested in something or doesn't feel well. Your kids. You don't have kids. Everybody else has kids. Okay, so when your kids get sick, and they're really sick, and they're running a high temperature, what happens to their eyes? They're not bright and interested and interactive anymore, right? They're dull. They don't want to interact. And you can tell by looking at someone that they're sick. All right. Okay. So, there's some bleeding that we don't want to try and control. What kind of bleeding do we not want to try to control?
Anything coming out of the ears.
Anything coming out of the ears. Why not?
You don't want to build up pressure, back pressure.
Right. You don't want to build up back pressure. What does bleeding from the ears, or what can bleeding from the ears indicate?
Brain injury.
Skull fracture.
Skull fracture. Yeah. So something has happened to the skull and you're bleeding out of the ears. And if you try and stop that bleeding, where's it going to go?
The brain, probably.
Yeah, probably back up into the skull. Is that good for our brain? No. Because we want to get that pressure out of there. That's why when people suffer from head injuries, they sometimes cut a portion of their skull out. When they cut it out, they stick it in their abdomen so that it can stay alive until they're ready to put it back in. Okay? That helps to relieve the pressure on their brain so that the swelling doesn't cause more damage. Right? Okay, so we know that we do not want to apply pressure to the ears. Now, how can we tell if we're dealing with a ruptured eardrum or cerebrospinal fluid?
You can get a drop of it on like a dressing and then see if it makes a yellow halo.
Yeah, you can try the halo test, right?
Western blot, or is that something different?
Isn't that like a Rorschach test? Like, here's a blot, what do you see?
Oh,
I don't know.
okay.
I don't know either. Okay. So we know that we don't want to apply pressure to the ears if there's bleeding there. Even if we can tell that that bleeding doesn't seem to be bleeding from cerebrospinal fluid or bleeding with cerebrospinal fluid in it, we still don't want to apply pressure, right? We can try and clean it up, but we don't want to apply pressure. Okay? What about a nosebleed? First, what is the medical name for a nosebleed?
Epistaxis.
Yep.
Epistaxis. How do we treat epistaxis? Pressure,
Or cold.
pressure or cold. Okay, what is cold going to do?
Cause vasoconstriction.
It's going to cause vasoconstriction. Okay, where are we going to apply pressure to?
Yeah.
The bridge of the nose. So where is the bridge of your nose? Do you know why it's called a bridge? There's a spot there where it moves from bone to cartilage, and that's a bridge. Okay? Now, if the bleeding from your nose is caused by something that you can stop the bleeding by pressing there, please, by all means, press on the bridge of the nose. What position do you want your patient to be in when you're doing that?
Kind of leaning forward.
Leaning forward. Why?
Just keeps the blood from going to the back of their throat and choking them basically.
Choking them? Or where's that blood going to go? If they're conscious enough to swallow, where's that blood going to go?
In their stomach.
In their stomach. Why do we not want blood in their stomach?
Throw it back up.
They're going to throw it back up. Okay? So if they're conscious and we can, we want them to lean forward while we're applying pressure to their nose. Okay? The problem with nosebleeds is that you're not likely to see all of the bleeding that's actually happening. Despite our best intentions, despite leaning all the way forward, they're likely going to lose some blood down the back of their throat. When you're done and you have the bleeding under control, you can't really apply a bandage. I mean, I guess you could. You could apply a bandage. But your body should have applied a bandage for you, right? You're going to have clots up there, or your patient's going to have clots up there. And the last thing that you want them to do is blow their nose. What's going to happen if they blow their nose?
Start it all
Clear up
over
the
again.
clots. Start to bleed again.
Yeah, they're going to dismiss all their clots, and we're going to have another bloody nose. Okay, so we don't want that to happen. Okay, we are going to talk about using a tourniquet. And we have here at school, we have one type of commercially available tourniquet. That's this one. It's an SOF tactical tourniquet for control of severe hemorrhage for use by qualified personnel only. Okay, this tourniquet,
Very tactical.
this one's kind of backwards. Okay, here we go. So this tourniquet is fairly simple to use. And I say simple to use, and yet I still, every semester, have kids who mess it up and don't use it correctly. Okay, so Corey has already examined these tourniquets and has found them to be lacking, but because he doesn't like this little claw right here, okay, because he thinks it can fail. And he's right, it can fail. But this is what we have here, so this is what we're going to practice with. You're welcome to practice at your station if you have something else. You can also practice with a triangle dressing and a pen, or a triangle dressing and a stick, or, you know, whatever. What's the purpose of applying a tourniquet?
Stop bleeding.
Constriction.
Constriction. Okay. Can you look and see how much time I have left on that? What time are we at?
19.
Okay, we'll probably be okay. Okay, so the purpose of the tourniquet is constriction, right? And it's to stop bleeding. Now, in order to stop arterial bleeding, you have to apply enough pressure that the pressure is higher than the person's blood pressure. Make sense? So if we were to use a blood pressure cuff as a tourniquet, which I don't recommend, let's not do that. But if we were to use a blood pressure cuff as a tourniquet, in order to stop an arterial bleed on me, you'd have to apply approximately 100 pounds of pressure to stop 100 pounds of some millimeters of mercury is what my blood pressure is, yeah. So you'd have to apply that much in order to stop an arterial bleed for me. What's your systolic blood pressure?
120-ish.
Okay, that's typical. What about you, Jared?
About 130.
Okay, Adam?
No clue.
No clue. Great. Somebody will take your blood pressure before we leave today.
Cool.
Dusty?
It's hard to say. I'm all over the place.
That's true, you are up and down.
I don't know.
Chief?
Somewhere in the 130 area.
Okay. So as you can see, just from listening to your numbers, those of you who had an idea, it's going to be easier to stop an arterial bleed on me and require less pressure than it's going to be on the rest of you. My average systolic blood pressure is in the mid-90s. That's normal for me. That's where I'm normally at. Okay? The rest of you are higher, so it's going to take more pressure. So when we apply this, we might have to twist it an extra time in order to stop the bleeding for you guys. Now, the way this tourniquet works is you have this nice little strap right here. And I'm going to pretend this is an arm because it's here, and maybe I can hold it in front of the camera because there's people who aren't here. So we're going to take this tourniquet right here, and it's best if this is on the front, but if you put it on the back, it doesn't really matter. You're just going to go around your patient to do it. Okay? So we're going to wrap this tourniquet around our patient. And this tourniquet isn't going to fit this bottle very well, but we're going to wrap the tourniquet around our patient here. Okay? Yeah, come on up and give me an arm. Now, it used to be a recommendation that you place the tourniquet about 2 inches above the injury. Okay? So that's no longer the recommendation. It's at the attachment point. So, if we have a bleed right here, we're going to pretend, because this is our right antecubital fossa. Remember I told you that we'd hear that at some point in time, right? Okay, so this is our right antecubital fossa. Hi, my name's Susan. I'm an EMT. Can I help you?
Yes, please.
Okay, so the first thing that I'm going to do is I'm going to make sure I've got my BSI on, right? Then we're going to apply direct pressure with a bandage, which they're in there, by the way.
And this one?
Yeah, it's okay. Don't worry about it. And then your evaluator is going to say, the wound continues to bleed. You're going to say, okay, well, I should bandage that. Or, sir, you seem like you're conscious enough. You're not going to tell them that. Would you mind holding direct pressure right there? That's a great example of diffuse pressure. Let's go right here with direct pressure. Okay? Wonderful. Okay, then I'm going to take this tourniquet right here, and as gently as I can, because I'm about ready to hurt him, I'm going to slide it up on his arm as high as I can get. Remember, we're no longer going 2 inches above the wound. We're going to the attachment point. And I need to slide this in here, into these teeth. Okay, and I want to make this as tight as I can before I start twisting. Once I get it on as tight as I can before I start twisting, I need to take this little screw, and I need to screw it all the way in. What is the purpose of this screw?
Stop somebody from
Locking
bumping
that
that.
jaw down.
Yeah, it's trying to lock the jaw down so the jaw doesn't slip, which is what our dear friend Corey here is worried about. Okay, now, my patient is still holding on to this because he's still bleeding. Okay, and I'm going to go ahead and I'm going to start twisting. On a typical patient, on a patient who's actually bleeding, I'm going to twist until what happens?
No more bleeding.
Bleeding stops.
We have no more bleeding, or what?
You lose distal pulse.
I lose his distal pulse. I can tell that I haven't done it tight enough because he still has a radial pulse here. Okay? I'm going to say that I tighten it until the bleeding has stopped or until I've lost a pulse, and then I'm going to secure it with one of these little triangle clips right here. Okay? This is a fairly simple tourniquet to use. Really, the only way you can screw it up is if you don't tighten down this bolt. Because if you don't tighten down the bolt, it's going to slip. Once you apply a tourniquet in the field, you don't release it. Fair enough? Okay. At this point, your evaluator is going to say to you, your patient is now exhibiting signs and symptoms of hypoperfusion. And I'm going to say, oh, sir, are you okay? Can you sit down on the floor for me before you fall?
Oh, is that done?
Yes, please. Okay. And do you feel the need to lay back at all? Here, let's lay you all the way back. All right. Okay, I'm going to get my oxygen at 15 liters by non-rebreather mask because I just talked to him, so I know he's conscious and alert. I'm going to get my oxygen. I'm going to make sure I place him correctly. Go ahead and lift your feet up or I'll lift your feet up. Okay, go ahead and set him down. This chair is perfect upside down like that. Okay? How much room is this?
16 inches.
Yeah, that's easily 6 inches. If I were to leave it upright, that's too high. That's more like 24 inches, right? But if I turn it over and use this, it's perfect. So we've got 6 to 10 inches, he's got oxygen on, and I'm gonna get my blanket, and I'm gonna cover him up with a blanket to make sure he doesn't lose any heat. Then the last thing I'm gonna do is I'm gonna make sure that I transport him. Okay? Now, if you are following along in your bleeding control and shock management skill sheet, I just aced that skill.
It's the attachment, so it's not like, say it was down farther, you wouldn't go like right above the elbow?
No, all the way up into the
All the way in the
armpit.
short, okay.
Armpit or up into the attachment point of the femur.
Okay. Interesting.
Gotta relearn.
Yeah, that's weird.
Okay, questions?
No, that was it.
All right.
The skill sheet doesn't say to bandage it.
No, it doesn't.
Is that something?
It doesn't. However, if you go back, if you go into your critical criteria,
Oh,
Dangerous or inappropriate intervention.
yep,